Yeah,
And another patient, CD, this is a lady who is now 45. I haven't seen her for the past 25 years. I've seen her as like a college student and treated her. Then she went into marriage. She has 3 children. She is very successful, professionally very successful. And actually now she has migrated to UK and doing extremely well. Once in a while she says that there is a small rash there. Should I do anything? Okay, so this is a story about CD. Okay, and third patient, EF. Okay, so she's again a 40-year-old female. She came with lupus manifestations when she was about 22, 23. She had mucocutaneous manifestations. She had mild proteinuria, few casts, and again she was picked up, treated, and then in a year's time the renal disease went into remission, and she repeatedly gets a scleritis. She's about 40, and for which other causes have been rolled out. It's immune mediated, but she just needs a low dose mycophenolate 500 milligram twice daily, and then she's quite fine. She's carried on with the normal activity. And another lady who's 60, again, she was diagnosed when she was 30, and she had a nephritis. She had a thrombotic manifestation also, and she went into developing avascular necrosis. And her lupus nephritis again went into remission. And recently, when she was 53, she developed a psychotic episode with some evidence of disease activity, and she developed NPSLE. And then she was managed for the NPSLE with immunosuppression, and she was all right. So obviously, is this all one disease? It's a problem. So that, like, they behave so differently, so differently. So this is a background in which I would like to have this session. So one of the important things or changes in lupus, understanding of lupus is we have understood if you pick the disease early, they do well. If you treat the disease aggressively early, they do well. The long-term outcome is much better. And so that is why when you look at criteria, you want something which will pick up the disease early. And when you immunosuppressing, you need a reasonable specificity also. So it is in this background that you always try to revise the classification criteria on how you diagnose lupus. So this is the latest criteria we have in 2019, of which one of the entry criteria just to weed out false positives is ANA positivity. So unless you are ANA positive, you would diagnose lupus according to the 2019 ACR criteria, and that too by HEP2 cells ANA positivity. And then you have the criteria, the clinical domain and the laboratory domain. And when you look at the clinical domain, you want to make sure that these manifestations are not due to something else. So and this is a weighted score. Basically, each symptom given a particular score. So you have a constitutional symptom of fever or hematological. You could have a leukopenia, is called 3, thrombocytopenia 4, or autoimmune hemolysis 4. But in one particular domain, you can only take one feature with the highest score. Suppose you have a patient who has hemolytic anemia, thrombocytopenia, and leukopenia, you would score them as 4. Okay, so that's about hematological. Then you have a neuropsychiatric domain, of which a seizure having a score of 5, psychosis 3, and delirium 2. Then you have mucocutaneous manifestations. We all know that mucocutaneous could be specific, non-specific, and if there is an acute cutaneous lupus, then you have a score of 6. I'll come to later on as to why you score 6 for that. Or you have an alopecia, non-scarring alopecia, you just score 2, or subacute cutaneous lupus of 4, or oral ulcers 2. And then serosal manifestations, serositis, musculoskeletal manifestations, and then renal manifestation, of which, suppose if you have a renal biopsy of proliferative lupus nephritis, you score 10. And then you have the antibodies also, the immunological domains. And when you look at these criteria, these weighted criteria, generally the cutoff is described as 10. So this is another study done in China, where they validated the 2019 ACR criteria. And if you score 10, you have a sensitivity of about 97% and a specificity of about 95%. So sort of reasonably good criteria for use in daily clinical use. As we all know, like classification criteria are meant for research settings, but still. So as I mentioned before, you have a wide spectrum of patients who we together call as, to our current understanding, we call it as lupus. And this is, you all should understand that as we went through the criteria, basically it's a phenotypic diagnosis. There may be many different things which could express the same phenotype. And currently, we classify disease based on the phenotypic expression. And so that's why we put all these, despite all these things, all these 4 different patients looking very different, they would have very different disease, but we put them together because phenotypically there are some features, like some clinical features or some serological features which fit into what we call as lupus now. So that's why, just coming to understand the disease, age, sex, we all know it's predominantly a disease of women with a 9:1 ratio. But before puberty or as age increases, this ratio comes down. And in children and particular age, it could be even almost equal. Second thing is, so is the adult, what we call as the adult lupus and the juvenile lupus, where you have the onset of lupus before 18 years of age, are they the same entity? And people have looked at the varying genetic variations in both these adult and pediatric and juvenile lupus. And there are many variants, genetic variants, which have been strongly associated with one form of the lupus than the other. So they have, I'm just not going through all those variants, but they have so many documented variants which may be present only in either juvenile lupus or in adult lupus. And these are some of the gene variants which have been clearly associated with juvenile lupus. Again, the way lupus presents is different in different populations based on the genetics of the population. So what we have the data is in the specific populations which have been shown. Now, why it's important to recognize whether this given patient has juvenile lupus or adult lupus, childhood lupus or adult lupus. One thing we know, antimalarials, the use of antimalarials, you need much when you give the medications based on the disease. Children need much more antimalarials, significantly more antimalarials than adults. Or the steroid, the amount of steroids which need to be used in childhood lupus is more than adult lupus. Or even parenteral IV glucocorticoids, which we know we use in severe disease, is more in childhood lupus than in adult lupus. And use of immunosuppressants is almost twice that in childhood lupus compared to adult lupus. And again, use of mycophenolate mofetil almost thrice that in childhood compared to adult. So also azathioprine is almost similar, methotrexate similar, biological is also 3 times that of adult lupus. And this was a huge database, almost like 18,000 patients from US, and the treatment pattern on pediatric and adult patients in lupus. And this was compiled together by a group in US, and one of the authors is Athimalapet Ramanan. Any idea where is Athimalapet? About 10 kilometers from Bagayam. You just go down Bagayam, and so he's a graduate from Stanley, and he's one of the authors of this study. So he's from here. So you do come to our department once in a while. So so that was people with adult already established lupus. This is almost similar data when we just recruit only patients with newly diagnosed lupus. This data is also very similar. So I'm not going into detail, and all of them have shown the clinical significance also. And so that's why we need to know whether the patient has an adult lupus or a childhood lupus. Now coming to sex. You know, it's like if you take it as 9:1 ratio female to male, do they behave similarly? So this is one of the illustrious cohort for lupus, something called as a Lumina cohort in US. It's like, it's called the Lupus in Minorities, Nature versus Nurture. It's like a long-term follow-up patients. They have about 618 patients, of which they looked at, does the clinical manifestation vary between male and female? So in the Lumina cohort, they came across that the musculoskeletal manifestations were more in males, while the organ damage accrual was more in women. This is another large cohort, the Hopkins cohort, about 1,900 plus patients. Again, males had higher levels of lymphopenia, anti-Smith antibodies, lupus anticoagulant, lower complement levels, and anti-DSDNA antibody. While in clinical manifestations, men had more neuropsychiatric, renal, cardiovascular, and peripheral vascular disease, while women had more skin manifestations or musculoskeletal manifestations. So there are about 4 or 5 large cohorts, which shows that probably the clinical manifestations of men and women may not be exactly the same. And overall, an indication saying that probably the disease is more aggressive in men than women. Again, lupus nephritis is more frequent in men, and there is a poor renal outcome and poor overall survival in women. And diffuse proliferative nephritis is again more in men. Let's skip this slide. And so we spoke about the age, we spoke about the sex, and about race. So this is California Lupus Surveillance Project, where again they looked at the incidence and prevalence of lupus in different ethnic populations. And so the In green, what you have is the incidence. In purple, you have the prevalence. So the incidence and prevalence is much more in black population compared to any other population, almost 4 times that of Asian and Pacific Islanders and Hispanics. But in Caucasians, it is almost half that of Asian and Pacific or Hispanic population. So that's regarding the incidence and prevalence of the disease. And coming to nephritis, if you take as the Caucasian population as reference, the non-Hispanic blacks have about 1.7, the hazard ratio is 1.7, and Asian and Pacific Islanders is 3.7. So if you're an Asian, the chance of you getting a nephritis is almost 3.7 times that of compared to the Caucasian. So that's regarding the genetics. And lupus, typically when we are in the OPD, classically what strikes us is the skin manifestations. But does all the skin manifestations mean lupus? So you can have a cutaneous disease and you can have a systemic disease with some overlap. And as we all know, as I mentioned before, remember what was the score for acute cutaneous lupus in what is the weightage for acute cutaneous lupus in the ACR EULAR 2019 criteria? 6. So you understand why. Almost all patients with acute cutaneous lupus have a systemic disease. While subacute, a very small population may have a subacute systemic disease. Neonatal lupus, very few children may have lupus. And coming to cutaneous disease, DLE mostly remains as a skin disease, but very few patients it may progress to a systemic disease. And lupus paniculitis, again, generally what we see in the OPD, most of our patients, it may remain as paniculitis and that needs to be treated. So most of them have a cutaneous disease and very occasionally they might go on to develop a systemic disease. And lupus tumidus, lupus hypertrophicus, they all remain as skin disease. So it is deciding on, once you decide that the patient probably has lupus erythematosus, which of these is important because depends on how you evaluate them and follow them up. So just a summary of what I presented now. So you can have acute cutaneous lupus, which could be a malar rash, oral or nasal ulcerations, maculopapular rashes, or even rarely a toxic epidermal necrolysis like presentation or a non-scarring alopecia. Then subacute cutaneous, which could be annular or psoriasis formulations, which I'll show some figures. And in between, you can have intermittent cutaneous lupus or lupus tumidus, which remains like a skin disease. And we have the chronic cutaneous lupus, which could be discoid, which could be discoid itself could be localized or generalized, or paniculitis, what we said, or chilblain lupus. So these are actually the one in the circles are the manifestations which are specific for lupus. So you make a diagnosis of lupus based on that. But those in the boxes, in the rectangles, are manifestations which are non-specific, but which could be commonly found in lupus, but it can be in many other connective tissue disease or non-connective tissue disease conditions also. So just a quick word, I think it's important, when you see it as, so I think I made the point clear, like why it's important to identify what the skin lesions is. So you have skin lesions, which indurated skin lesions, which are targetoid, which could be in acute cutaneous lupus, which could be the malar rash or be any other part of the body, indurated erythematous skin lesions, which you make a diagnosis of acute cutaneous lupus. Or you have subacute cutaneous lupus. Generally, they are widespread, but one good thing about them is they don't scar, and many of them are associated with scaling, depigmentation, and you can have associated telangiectasias, and they are distributed in the photosensitive areas. So this is subacute cutaneous lupus, and this is chilblain lupus. Again, I put it as cutaneous lupus. Basically, extremities presenting like something would look like a severe Raynaud's with painful, discolored extremities, which can even become cyanotic. So this is important for chilblain. It's like you could have easily called it like a severe Raynaud's. And lupus paniculitis. So you have paniculitis resulting in loss of the fat tissue and the characteristic appearance of the lost fat, which could be any part of the body, which could make a diagnosis of lupus paniculitis. Now coming to discoid lupus, these are the lesions, which are discoid lesions, which is scarring, leaves a scar with hypopigmentation or unpigmented areas, which could be mostly commonly seen in the head and neck areas. So the different manifestations of discoid lupus. So having I thought I made the point clear between how you differentiate acute cutaneous, subacute cutaneous, and discoid lupus, and why it's important to differentiate them. Just a word about drug-induced lupus. Particularly in tertiary care center, we use so many medications which can cause lupus-like manifestations or lupus per se with ANA positivity without any major organ involvement. The common drugs could be the one described, including TNF inhibitors, and which can cause a drug-induced lupus. Other drugs, carbamazepine, sulfasalazine, isoniazid, statins, antihypertensives, lithium, phenytoin, levodopa. So all these medications can cause lupus, particularly lupus with the skin manifestations without organ involvement. So it's important for us to be aware of that. And since thrombocytopenia is a major manifestation, there can be many drugs which can cause thrombocytopenia, which include our common drugs like penicillins, cephalosporins, carbamazepine, sulfonamides, phenytoin, vancomycin. So we have to bear that in mind when you approach somebody with thrombocytopenia. And this could be in somebody with lupus. You treat somebody with lupus, they go into remission, they have no disease activity, but still you have trying to figure out what is this thrombocytopenia due to. So there are quite a few drugs which could cause thrombocytopenia. Again, thrombotic manifestations of lupus, there are drugs which could cause thrombotic microangiopathy, but which could be generally dose dependent and cumulative. And again, this also is an immune-mediated process. So there are drugs like cyclosporin, tacrolimus, TNF inhibitors, quinolones, valproic acid, penicillins, ciprofloxacin. Many of these medications can cause an immune-mediated thrombotic process, which can present as a thrombotic microangiopathy. And again, hemolytic anemia being one feature, drugs can cause an immune-mediated destruction of RBCs and causing an oxidant injury. And it could be within a short time of few days to weeks of exposure of the new drug, which can cause hemolytic anemia. So which is the drugs which are known as include NSAIDs, antibiotics, and carbamazepine and cyclosporin. So in approaching the patient, as we all know, lupus has a major immune process activating the disease. So what is it due to? Is it like a disease of the innate immune system, or is it like an adaptive immune system? There are quite a few diseases of the innate immune system where you have, high-grade fever, arthritis, which could cause like high cytokine-related manifestations, which are called autoinflammatory disease. At one spectrum, you have a disease called autoinflammatory disease, and the other spectrum you have something called as an autoimmune disease, where you have a lot of activity by the adaptive immune system. In the autoimmune disease, you can have specific gene mutations causing disease, including your chilblain lupus. A chilblain lupus is basically mutations in TREX1 gene, which can cause a monogenic lupus. Or generally, the common garden variety of lupus, what we see is a polygenic autoimmune disease, like rheumatoid arthritis or myasthenia gravis. And still, there is a component of autoinflammation or the immune system acting in lupus. So basically, it is just a single slide on hinting on the pathogenesis, where you have, even though it's a predominantly adaptive immunity which is happening in lupus, you have a significant contribution from innate immunity which activates the lupus. Now coming to the autoantibodies, I'm not just going through all our routine antibodies, which all of you are quite familiar, all of you order, just about because the prothrombotic predisposition for lupus. About 1/3 of patients with lupus have a lupus anticoagulant, and close to 1/3 have an anti-cardiolytin antibody, and 1/5 have antibodies to anti-beta GP1. And if you look at the other way around, if you look at all patients with lupus anticoagulant positivity, 50% of them would be having lupus. So why is it important? So sometimes the thrombotic manifestation might be the first manifestation for the patient, or you pick up a patient or clinical indication for doing a lupus anticoagulant, and there is a 50% chance that this patient would be having lupus. Now coming to the organ involvement, one of the so broadly we could say put them into renal and non-renal manifestations of lupus, because there's a high prevalence, and renal involvement is the one which many times decide the mortality and morbidity for the patient. Renal manifestations become so important, and the risk factors for patients to go in for end-stage renal disease is a male sex, a black race, presence of antiphospholipid antibodies. If at the time of diagnosis the creatinine level is high, or if the patient has anemia, or patient goes into partial remission or complete remission and then have repeated nephrotic flares, or if the patient is hypertensive, or the proteinuria is prolonged. These are all risk factors which has identified for the patient to progress into a end-stage renal disease. So how do you manage lupus? So as I mentioned, I would go through an overview of the lupus. Then 1 hour may not be enough to look into all the various aspects of lupus. So I just thought put the management of lupus together. So this is a recommendation by ACR EULAR 2023 on management of lupus, and how they come to these recommendations. How committees come through recommendations? Somebody can. They do something called the Delphi technique, So they bring in experts on various aspects of the disease and various stakeholders. So this would include rheumatologists, nephrologists, patients, policymakers, statisticians, and then they'll have few registrars also who has to do the work to collect the data. And then they generate questions, clinical questions which come from our OPD or our inpatient settings. And then they try to look at the evidence for those questions, and these are the possible solutions. Like if you have discoid lupus, should you give HCQ or not? And then they look at all the evidences which have been published, the quality of the evidence, and so the possibilities are can give, cannot give. And then all the experts put together, they score it. And then they look at the agreement among the experts. So if you have a 100% agreement by the experts, then it comes as a recommendation. Or if there is, so lower the agreement between the experts, it doesn't come as a recommendation. Okay, so that's how the recommendations are made. So then what is the problem with that?
there can be a bias. We are not there. We see so many lupus. So in India or Bangladesh or Pakistan, we see so many lupus, and we follow those recommendations. So actually, but one different thing is this Delphi had few representatives from Asia as well. So because because it's like a expert, a little better than an expert opinion based on what are the evidences till then. So we have to always keep this in mind when you follow recommendations, because when they make the recommendation, they may not have the picture of my patient who's sitting with me there. With she doesn't have money to buy HCQ even. Then how do you? Then the recommendation says give rituximab. Or she doesn't have even possibility of seeing a rheumatologist. The only person she can see is a primary care physician. The recommendation says the management decision should be a joint decision by a rheumatologist, nephrologist, everybody else. So you may not be able to apply all those things, but we have to keep that in mind. Okay, but this is the best available. That's what we have. So one of the important recommendations for lupus. So as you would come see that if it's a green color, it's like a grade 1 recommendation. So all patients with lupus nephritis should get HCQ unless it is contraindicated. Where does HCQ get contraindicated? Somebody has a maculopathy due to some other reasons. Somebody is on tamoxifen for some other reason, or conditions which can increase the HCQ toxicity, like somebody with a pre-existing renal failure. So any of these conditions, then you can't use HCQ. Otherwise, always, everybody, all lupus patients need to get HCQ. Okay. Then the next thing is glucocorticoids. So that's also like the grade 1 recommendation. All of us know the mainstay of treatment for lupus or lupus in any form is glucocorticoids. And one of the clear recommendations, like maybe like 10, 15 years back, when we used to treat lupus, we used to give them like high dose steroid with 1 mg per kg of steroid, which we continue for 6 weeks to 12 weeks, and then start tapering. So one of the things which has come up is this. A longer duration of steroid, cumulative dose of steroid is associated with higher levels of toxicity. And you lose patients because of diabetes, hip fractures, or they're blind because cataract, you can't operate for some reason, or various toxicities, and much more common, infections. Okay. So one thing over the years which have come clearly is you need to use steroids. Steroids are the first-line drugs for any active lupus disease, but the smaller the dose, the shorter the duration, use the better. So for lupus nephritis, you consider pulse steroids if there is indication for a proliferative nephritis, or you have indications for a more active disease for higher renal disease progression. As I mentioned, some features below, like if somebody is black or high creatinine at presentation, or there are some features in biopsy. Suppose you do a biopsy and if you have a fibrinoid necrosis, or you have crescents, more than 50% crescents of the glomeruli, or of the interstitial fibrosis is more than 5 to 10% of interstitial fibrosis. All these tells you that these are patients who could go in for end-stage renal disease. So these patients would need pulse steroids. And patients without these severity manifestations, you could use 1 mg or higher dose of oral steroids. And once, if you're not using pulse, then you have to use a higher dose of steroids. But generally, the steroid dose is kept at 0.5 to 0.7 milligram per kg. So no longer very extremely unusual to use 1 mg per kg of steroids. And then, based on the response, you taper the steroids, and What about how long can we continue the low dose steroids? The before 2023 recommendations, generally we thought we can give 7.5 mg once daily. We can continue it for longer time, but the evidence closer to 2023. So basically, this is based on evidence what we gathered from 2018 to 22, and even 7.5 mg of steroids causes an increased morbidity or complications of steroids. So the current recommendation is when you need to maintain low dose steroids, keep it at 5 mg per day, 5 mg per day or below. And then lupus nephritis, the proven drug is mycophenolate mofetil and cyclophosphamide. Suppose you have, and if you don't have fibrinoid necrosis, you don't have, your crescents are very few, or if you have interstitial inflammation is less, you can use what we call as low dose cyclophosphamide. The low dose cyclophosphamide is what we call as the Euro-lupus protocol. So they basically use a 500 mg of cyclophosphamide fortnightly, give 6 doses. And that is the induction treatment. But if you have any of those features which I mentioned, then you go for a what we call as a high dose cyclophosphamide, or we call it the NIH protocol. You go for like 750 to 900 milligram of cyclophosphamide monthly for 6 doses. So that is one decision you take based on the severity of the proliferative nephritis. And so once you give, suppose it's a low dose cyclophosphamide you're deciding on, and then after the induction treatment of the 6 doses, you can go in for a maintenance with either azathioprine or mycophenolate mofetil. Or if you are inducing with mycophenolate mofetil, you can continue that. So these are options. And despite all these things, if you look at the data retrospectively, it's only about around 30% of people go in for complete renal remission, despite all what we do. So that is a problem. So still, actually, there is a lot of inadequacies, or we are we are a lot deficient in treating lupus nephritis. Because initially when you see a couple of visits, or you may have patients who go in for partial remission or complete remission, but they look at larger data retrospectively, only about 30% go into complete remission at 2 years. So we're trying to improve the treatment, and that is, should we add on something right in the beginning? One option is either you use mycophenolate or low-dose steroids and add belimumab, and then maintenance as before with belimumab, which is a anti-BAF. It's a B-side stimulator, an anti-BAF antibody, which can be used. Probably there is some data indicating that probably more of people may go into remission with that. Similarly, we have combination therapy. Now the shift in focus of lupus nephritis management is towards combination therapy. You start on with induction of remission with mycophenolate and calcineurin inhibitors. Actually, we used to do it before also, but the problem with calcineurin inhibitors are the one which we use as cyclosporin A or tacrolimus at the higher level of nephrotoxicity, more people going into hypertension or renal dysfunction. So that was a worry. So we was always been reluctant, but now we don't have it in India. But voclosporin is the calcineurin inhibitor which has brought in more people going into remission or better activity than the conventional calcineurin inhibitors. And high-dose cyclophosphamide, I mentioned about it. And actually, there are two situations. One, you have, so if you have a resistant disease, despite having all these sort of indications, that is when you have a role for rituximab. So as of now, the current recommendation is rituximab. Or there are some situations in reality, you just not able to give steroids for some reason, like either because of vascular necrosis or cell serous retinopathy, some reason. Then clinically we tend to give rituximab early, but the current recommendation is here. Having said that, the other most important aspect in management of renal disease, which all of you know, we all do in medicine, treatment of proteinuria, so ACE inhibitors or ARBs, and now I think many of us, like SGLT2 inhibitors are sort of standard recommendation in patients with proteinuria. There's enough data of that. And if one of the things is, if you have a resistant disease, is it because of thrombotic microangiopathy? Almost like 20% of lupus patients who are resistant to treatment, particularly if they have antiphospholipid antibodies, they could have a thrombotic microangiopathy. So whether if there is evidence of APS nephropathy or antiphospholipid antibody, another option is to think about anticoagulation or heparin. So that's about a brief overview of renal lupus. And coming to non-renal lupus, again, most important aspect, it's very important aspect. So we generally tend to focus on medications, but very important aspect in lupus management is sun protection, exercises. Fortunately, the smoking is less of a problem for us, but still have to make sure smoking is have to stop smoking, a balanced diet, vaccinations, normal, keeping the ideal body weight, keeping the blood pressure under control like you would do for diabetics, getting the lipids under control. And if there is possibility of a thrombotic angiopathy, about using antiplatelets or oral anticoagulation. And the most important again is, many of us think, the patients follow, we tend to sometimes treat the chart than the patient. And we assume many times patients take all these things. Many times the reason for a flare, a non-response, would be poor adherence to treatment. Actually, in that matter, we did a study on looking at methotrexate compliance in rheumatoid arthritis. Can you guess how many? What was our we faithfully increase the methotrexate from 10 to 15 to 20 to 25 and change from oral to subcut. But we say, oh my God, it's not responding. So then somebody looked at a non-doctor person, a nurse who's coming as not like a nurse, dressed as a nurse. Looked at that, she went to the patient, spoke to them, and looked at the complaints. Can you guess what is the complaints of methotrexate to rheumatoid arthritis? Some guess, so we get an idea about what is the complaints of the patient. Just 40%. So this is why one of the, in real life management, this is one of the most important aspects. So non-pharmacological measures, ensuring compliance are most important aspects. Here again, management, mild, moderate or severe disease. Because amount of time, I wouldn't go more detail into mild, moderate, severe disease. So basically, you can look at the ACR ULAB 2013 recommendations. This paper is freely downloadable, so you can take it. And HCQ again for all patients, and the dose of HCQ 5 mg per kg of the real weight of the patient. Actually, they found if you come down on the dose below 5 mg per kg, the chances of a flare is twice that of somebody who maintains 5 mg per kg. Or sometimes many patients ask, can I discontinue, because it's like, this is a tablet I've been taking for 3 years, 4 years. Can I discontinue HCQ? This is a common question, particularly when you have the skin pigmentation, late-grade pigmentation of the sun-exposed areas and all. So they looked at what happens when you withdraw HCQ. The chance of flare becomes 6 times. Okay, so HCQ is an important drug in following up in lupus patients. Then steroids, as I mentioned, you can start at a low dose of steroids and bring down to 5 mg and stop as quickly as possible, or if possible. Okay. Then other drugs which can be used for various manifestations of lupus are methotrexate, azathioprine, mycophenolate. So why are they in like lower grade recommendations? It's just because in clinic you know that it works and it helps patients. But this recommendation is based on data, evidence available, evidence generated. So there isn't much evidence generated to look at the minor manifestations and whether they make a difference in the outcome. So, so that is why these are in like grade C or grade 3, grade C, grade B and C recommendations. But still it works. And actually, belimumab, this is anti-VAF, I said, or anifrolumab, which is basically lupus is like an interferonopathy. Interferon levels are high, and that is well known to correlate with disease activity. So obviously, we give an antibody against interferons that should reduce the disease activity. So that is where anifrolumab has been used. Again, anifrolumab is given with the grade A recommendation because there is data generated, data available on anifrolumab making a difference in disease activity, mild, moderate disease activity. Then again, calcineurin inhibitors, cyclophosphamide and rituximab. Now the question is, one of the difficult questions to answer, how long to treat? So this is one thing which the first thing patient asks, and then every visit they ask. So generally, current recommendation would say if somebody has a major organ involvement, particularly like a nephritis, minimum 3 years. That sort of recommendation. So 3 years is no compromise on that. And beyond that, as I said, I said so many different sort of patients. So it has to be personalized. The way you decide tapering, whether you taper steroids or second-line agents or hydroxychloroquine, how you do it, it's heavily personalized and depend on how you know about the patient. That's one of the important things. If you have a same rheumatologist following up the patient repeatedly, you know how the patient has been doing over time. So this helps you to modify the medications or same physician treating. So you know how the patient is doing, you can decide on treatment. But the general recommendation is if you need to taper and stop medication, first to do is steroids. So that I think repeatedly has come up in these recommendations. Second, if you want to, like after you have sufficient period of patient in remission beyond 3 years, to taper would be your second line agent, which could be mycophenolate or azathioprine or methotrexate or calcineurin inhibitors. And the last thing to taper or stop would be hydroxychloroquine. So that's briefly about the non-renal manifestations. Another important area, difficult area to treat in lupus patients is the neuropsychiatric lupus. And this is one area which have a high prevalence, about 25 to 50%, and this affects the quality of life. And it could even predict higher mortality. And diagnosis is difficult. And the ACR in 1999 has put in these 17 different syndromes for neuropsychiatric lupus, which could be of the central nervous system or the peripheral nervous system. And there are focal neurological syndromes like seizures, septic meningitis, demyelitic syndromes, myelopathy, headache, cerebrovascular disease, movement disorders, anxiety disorder, psychosis, or neuropsychiatric symptoms. And peripheral nervous system, the various other manifestations which have been put across. And how do you diagnose neuropsychiatric lupus? Based on what clinical manifestation you're suspecting in the neuropsychiatric syndromes, and you target your investigations based on that. So whether you can use, there are several autoantibodies for the nervous system, whether we can use that for diagnosis of NPSLE. So we looked at our group of patients, and we had about 44 patients with proven neuropsychiatric lupus. And these were the different manifestations in our group of lupus patients. And 27%, almost 1/3 of our patients had some of the anti-neuronal antibodies. And I will not go into the details of the anti-neuronal antibodies. And these are the anti-neuronal antibodies and the manifestations which were there. And we couldn't find any particular antibody correlating with any neuropsychiatric manifestations. And of course, this is a small sample size from a single center. Again, NPSLE, how you treat inflammatory NPSLE, like we discussed about renal lupus or non-renal lupus, and thrombotic NPSLE, basically anticoagulation and antithrombotic. Just emphasizing that if whenever as much as possible, try to differentiate the two because the treatment could be different, but it's not easy on the clinics many times. And this is a study we tried to look at. We had about 30 patients with NPSLE, of which we had patients who treated with mycophenolate, cyclophosphamide, and or a combination of rituximab and cyclophosphamide, of which for mycophenolate alone our response was about 90%, cyclophosphamide our response was about 80%, and all our patients with on rituximab mycophenolate combination responded in management of NPSLE. But this is a very small single center, and it was not randomized. That you decide to give the decision to give mycophenolate or cyclophosphamide or combination rituximab mycophenolate was for the treating physician. So, but this is the data which we have. Let's skip the slide, I think for want of time. This is our data on rituximab. Again, our experience with rituximab in various manifestations of lupus is very promising, with varying response to. So basically, you give rituximab when you have a major manifestations like neuropsychiatric or renal, and how responses have been good. Just before I summarize, a quick word on pregnancy in lupus, which is again an important area. We all know any autoimmune disease which is Th2 cell mediated, they flare during pregnancy. So lupus is a Th2 cell mediated disease, so they tend to flare. And there are the different etiologic aspects of lupus could affect fetus, both the mother and the child. And a word about evaluation of a lady before pregnancy, the different regular routine investigations, including autoantibody, anti-dsDNA complements, ROLA antibodies, and antiphospholipid antibodies. And anticipating complications in pregnancy, it could be maternal outcomes or adverse fetal outcomes. This is one large retrospective data from US with 40 million deliveries of lupus and non-lupus patients together were looked at. And what are the data which came up is lupus patients tend to have 4 times more blood transfusions than other non-lupus group of patients. Then non-lupus would include maybe people with other diseases also, but they just compared lupus with non-lupus, or almost 15 times higher risk of renal failure when a lupus patient is pregnant, or cerebrovascular disease is almost 4 times the chance of eclampsia and DIC for a lupus patient during pregnancy is about 3 times, and peripheral vascular disease almost 11 times, and intrauterine growth restriction 2.5 times, and preterm delivery almost twice. So these are the sort of problems we could face when a lupus patients become pregnant or during delivery. And our medications, I think all of you know about these things. Calcineurin inhibitors are safe during pregnancy, azoran is safe. Just a word about steroids during pregnancy. Steroids during pregnancy can cause premature rupture of membranes, IUGR, or preterm death. So just that you need to give steroids need not always be as good as we would think. So that's about quick view on pregnancy, and a word about vaccination. As we know, the disease per se predisposed person for these patients for infection, and you are aggressively immunosuppressing them, again predisposed for infection. So do we vaccinate? Should we vaccinate? Does vaccination produce adequate response? We generally, the recommendation, and what we do in CMC also, we vaccinate both influenza, pneumococcal, herpes vaccine. To keep in mind is, if you have rituximab, the antibody response will be very poor. So planning rituximab, you need to vaccinate them at least 4 weeks ahead. All the other JAK inhibitors, the response to pneumococcal vaccine has been poor. Methotrexate, again, the response to vaccination is not good enough. So methotrexate, rituximab, no. Methotrexate, we tend to stop the methotrexate for 2 weeks after vaccination to get an adequate antibody response. JAK inhibitors, flu vaccines are okay. Pneumococcal vaccine may have to give a drug holiday. So that's briefly about lupus. I think I was supposed to stop at 2:30. Yeah. Thank you. Any questions? Sir?
Thank you so much for the lecture. Any questions from the audience?
Yeah.
I have a question.
Yeah.
It is not organ, life-threatening organ manifestation, like a pancytopenia or recurrent infections.
Yeah.
Those we give like 0.5 to 0.75 steroid, and same way we taper in 2 to 3 months, and then we choose second line.
So with infection, then you treat the infection, but the pancytopenia, like particularly thrombocytopenia, the thrombocytopenia is low. If it's below 20,000, 22, beyond 20, it's fine. But below 20 and there is a risk of bleeding, then you have to give high dose steroids. Or other option is IVIG. So thrombocytopenia is one situation you can give IVIG. So also, if there is a leukopenia with infection, IVIG is a good option. Sorry, there was a note on IVIG, but it's an odd situation where we use IVIG.
But we give pulse steroids mainly neuropsychiatric, renal, and hemolysis.
Yeah. And thrombocytopenia also if there is no infection. And renal again, not all renal. If you have a bad prognostic factors on biopsy or clinical parameters.
So this neuropsychiatric SLA, I mean, the diagnosis is always shaky. We've had some patients who finally after ruling out everything else, we're just like, this must be. Is there anything that will aid us? Because everything is just a supportive investigation, which may or may not. And many this viral encephalitis bar autoimmune encephalitis. Is there anything we can do to, or any particular pattern we should look for?
Yeah, actually, no, actually somebody has headache. There is a neuropsychiatric manifestation. But if you include headache as a neuropsychiatric lupus, then 80% of lupus patients will have NTSLE. So NTSLE is one area which is sometimes difficult to diagnose because of the associated electrolyte imbalances, infections, and steroid toxicity. So many of your drugs themselves can cause, like steroids can cause neuropsychiatric manifestations. So NTSLE is one area, sometimes it's difficult to, and many of times, and another problem there is whether you don't know whether it's a thrombotic manifestation or a antibody-mediated tissue damage. So many times in reality, on the bedside, you tend managing both. You tend managing the disease, sometimes you managing giving anticoagulation or heparin, and of course, infections sort of, other than encephalitis, you can do a CSF and inflammatory markers. So infections sort of fairly okay, except for maybe some encephalitis.
So there's a question online. Patients who are diagnosed SLE and are on follow-up, in our setting where they may have financial constraints as well, what are the basic investigations that are a must to do on a follow-up basis, and how often do we need to repeat a DST?
Actually, two things. One is establishing the diagnosis of lupus and establishing the organ involvement. So common organ involvement is nephritis, which you have a urine microscopy and protein estimation, which doesn't cost much, or the basic counts of hemoglobin total differential and platelet count, which doesn't cost much. And so you first you establish the organ involvement, then follow investigations as such is not really costly. And clinically, if you are the same physician seeing the patient, you may not, ideally yes, but practically you don't have to do anti-DSDNA and complements every time, because you can assess the disease activity, organ damage by the other factors also, and you know whether the patient is going into remission or not. So practically from our situation, you can't do DSDNA or C3C for every visit, but ideally, at least every year, all organ systems should be evaluated for the damage, organ damage.
Yes. Any other questions?
Now, most of our patients come with newly diagnosed SLE might be currently having an infection also.
Yeah.
So for these patients, is there any benefit of starting if anemia is quite high, is there any benefit of starting low dose steroid initially itself? Because SLE might be also end up to stay.
No, we have to treat the lupus. If the how you treat the lupus depends on actually not on the serology, on the organ involvement. If you have hematological involvement, renal,
If there is no endocrine damage as of now.
not endocrine activity, disease activity. So damage may not be there because particularly early disease, there won't be damage, but disease activity, like you have acute cutaneous. Somebody is acute cutaneous, there is a active disease, immune complex, and complement recruitment happening. So acute lupus, you have a cast in the urine, you have proteinuria, you have hematuria, or you have counts which are dropping. So all this gives you an indication that disease is active. And if you don't treat, even the infection will not get controlled. You have to treat the lupus. And the steroid has to be, that's a judgment you have to make between antibiotic for sure, because there is an infection, and the steroid dose based on the activity. How much you go, generally we tend to give shorter acting steroids like hydrocortisone, which at a dose equivalent of 0.5 to 0.7, depending on the activity, or 0.3 to 0.5 mg per kg, equivalent of hydrocortisone. So it's like a short acting.
Thank you, sir, for that lecture. Please join us for lunch afterwards.